Good afternoon, and welcome to Optimizing Your Imaging Approach for the COVID-19 Fight, a Health Systems CIO Media Inc. production sponsored by Hyland Healthcare. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health Systems CIO, and I will be your moderator today. We've got some interactive features we're going to be taking advantage of today. Questions and comments, you could send them in that Q&A box at any time. We'll take them later in the program. We have a quick audience poll we'll do later, and you can download the deck by using the URL on your screen, and it's been sent out in the chat box. Just so you see how we're going to spend our time today, we're going to go about 35 minutes with our main panel discussion featuring Joseph Marion, Principal with Healthcare Integration Strategies, Brandon Taggart, Founder and Principal Consultant with Konfidi Healthcare IT Consulting, and Chris Magyar, Senior Product Manager, Enterprise Medical Imaging with Hyland. So let's jump right into our discussion. Joe, let's start with you. Can you give me an overview of your organization and your role?
Sure. I've been in healthcare for 40 plus years. I've spent 20-some years with a major equipment vendor in imaging, and have been on my own for 20-plus years in terms of consulting and starting with PACS and emerging into enterprise imaging, addressing both radiology, cardiology, and all of the ologies in some instances. So that's pretty much it.
Very good, Joe. Thank you. Brandon?
Hi, I'm Brandon Taggart. I'm founder and principal consultant of Konfidi Healthcare IT Consulting. We're a full-service consulting firm that provides strategic direction with regard to enterprise imaging, anything from assessment and discovery, RFPs, and implementation. My personal background, I started out in the clinical realm, then came out of the clinical and actually went into business world for a period of time in terms of commercial real estate, and then pulled back into the medical world to be a longtime consultant with Ascendian Healthcare IT Consulting. From there, I worked my way up and have had a lot of great experiences, worked with a multitude of organizations, both on the clinical, operational, and technical sides. At this point in my career, I think I've seen a multitude of different things, and I like to be able to lend my experiences to those that I might be able to help.
Very good. We're looking forward to the discussion. Chris?
Hi, Chris Magyar, representing Hyland. Hyland's a leading content services provider for multiple industries, but in particular for healthcare. Our solutions span all types of management capabilities for documents about the patient or medical images of the patient, including document management for back office solutions for the healthcare enterprises. I got into this space as a software engineer by training. I've been involved in writing or using software in some primary manner for probably well over 30 years. About 20 years ago, I got involved in enterprise imaging, developing some of the first vendor-neutral archives, and have been since involved in all types of enterprise imaging and radiology and all of the different specialties, produce everything from soup to nuts, software, hardware, tools, workflow, integrations, you name it. My particular responsibility right now is product management for Hyland's enterprise imaging portfolio of products and solutions, which includes technologies for image acquisition and workflow, storage, management, viewing, workflow orchestration, etc.
Very good. Thank you, Chris. Well, I have no doubt we have three of the most knowledgeable people you will find around medical imaging and dealing with moving to an enterprise approach, which we're going to discuss today. So we're going to be very topical and timely right now. So Brandon, let's start with you. Talk about the impact you think COVID-19 is having on health systems from an imaging point of view.
Well, from an imaging point of view, it's really the fact that we're having to operate in a remote environment at this point. A lot of radiologists are being sequestered to their homes and having to read remotely. For the organizations that have already prepared for this, For the most part, it's business as usual, but there's a few caveats there that become kind of problematic. Mammography comes to be one of them, in which most organizations have not set up appropriate parameters to be able to read mammography. There's also FDA MQSA guidelines that they have to follow. So those things become complicated and end up making kind of a sacrificial lamb, if you will, of some of the radiologists that do need to actually go in and be physically present. Luckily and not luckily, due to the COVID-19, a lot of those procedures, especially with mammography and outpatient procedures, have dropped drastically in terms of volumes. That has had a huge huge impact on not only imaging, but health systems as a whole in terms of the revenue. That is causing some major impacts and affecting the ability to staff effectively. So there is this calm before the storm with a multitude of organizations. We hear about San Francisco, we hear about New York, on the fact that it is obviously they're inundated at this point. But we also have all those other communities and even rural communities in which they haven't been hit yet. And in terms of the effects on them, it's those lowered revenues, those lowered volumes that are really affecting them. And they're sitting there wondering, well, how do we effectively manage this? Do we cut back our staff if we're waiting for the surge that's to come? Because all these patients are going to need to be seen. So those are the major impacts that I'm seeing out there currently. And it is a mixed bag depending on timeline of where they stand currently.
Very good. Chris?
I think Brandon did an excellent job of describing that. We're looking at our existing customers that have implemented our solutions to deal with some of the challenges that are coming up. The first one that Brandon mentions is the remote reading challenge. And that's sort of a really interesting technical puzzle, and we'll drill into that in some more depth here in a moment. Another interesting thing that we're seeing coming up is the increased use of point-of-care ultrasound for COVID-19 early assessment, and the notion of dragging a patient into your CT room to get a scan. It's an expensive process. You risk contamination. It may be completely appropriate for somebody who's got an advanced acute respiratory distress syndrome going on, but I think that ultrasound workflow is interesting as well. So those really trying to figure out how we go to our existing customers who may have invested in our technology from a clinical review, enterprise yield perspective, but perhaps not leveraged all of the diagnostic or particularly remote reading diagnostic capabilities. How do we help them in that transition? For those that, for example, may have invested in content services and not medical imaging at all, they may be struggling with issues with their existing medical imaging solutions in enabling that remote read, and there's a lot of interesting reasons for that. So how can we help them? And then we're also trying to reach out and say, how can we help net new customers who do not actually have relationships with Hyland today who are solving with these problems? Can we accelerate their path to addressing that remote read problem or the ultrasound acquisition workflow problem? So we really have prioritized heavily across many departments inside of Hyland. How do we come up with solutions that will help healthcare customers deal with this more quickly and effectively?
Very good, Chris. Thank you. Joe, your thoughts?
It's hard to follow those two eloquent comments. I think that I would just add that the key is going to be the widespread accessibility. So having the resources and capability to tie people in from remote locations and share information is going to tax hospital systems, particularly in terms of interoperability. So I think that the challenge is to make sure that the information that is acquired on any COVID patient is certainly available to the clinical staff, whether they're on-site or off-site.
All right, very good. Next question. Chris, let's start with you. We talk about the concept of an enterprise imaging approach? First, I think we should define that. So I'd like each of you to, before you answer the question, to give us a high-level definition of what that means to have an enterprise imaging approach. Do you think those, and we'll have the poll on this later, do you think those who have been moving in that direction are better equipped to deal with the current crisis?
Well, I'd say absolutely, because the current crisis is requiring organizations to deliver solutions for scenarios and workflows that they didn't necessarily anticipate. So if you've invested in more flexible enterprise imaging infrastructure, you're better positioned to move quickly to dealing with those unpredictable demands. And we talk about, well, what do we mean by enterprise imaging infrastructure? Well, you have to contrast it with the traditional investments. Obviously, we have a lot of image acquisition devices out there. And in the more established imaging specialties like radiology, we have workflows, we have order-based workflows, we have PAC systems, we have modality work lists, we have storage and management capabilities. There's abilities to integrate with the EMR, but they're all very specialty focused. They don't necessarily scale well outside of radiology. And the further you go out towards the edge specialties, the more likely you're going to move from a departmental specialty imaging system that may not integrate well with the enterprise to just free-floating acquisition devices that aren't integrated into any kind of meaningful workflow or capture mechanism. So organizations that have invested in enterprise imaging, they may have an enterprise mechanism for dealing with order and encounter-based workflow in any specialty. They may have storage and management capabilities for their medical imaging that spans all of their specialties and all of their facilities. They may have viewing capabilities that span all of the above that are integrated nicely in with their EMR. So you basically get a single view of the comprehensive patient imaging record. Organizations that have done this, and I didn't even get into infrastructure, but that have made those investments can look at the kind of demands that we just put on the table and move much more quickly to delivering solutions for that.
Very good, Joe.
I think one of the major challenges that we all face is the definition of enterprise imaging. And I think that's been one of the major stumbling blocks, is that there is no widespread, I guess, acceptance of a common enterprise imaging definition. So it can mean anything from tying a few image services together to all the way to the full implementation across all imaging services. And I think that the challenge is the drivers for what's pushing healthcare institutions in terms of implementation. So there's a lot of different and varying opinions on that, but the challenge is always finding a justification for a true enterprise scale solution. So avoiding duplication and replication, I think, is also paramount to making that happen.
Brandon, does the industry need an adoption model? They're out there for other things, EMR adoption models, different things have been put out by different industry organizations. Would that be helpful for somebody to come up with that?
I think anytime you have a level of standardization, it's going to be helpful to make things a little more cookie cutter, obviously, in terms of deployment and easing the complexities that come with that. The other thing that you might end up doing as a collateral damage, though, is causing some stifling of potential innovation and other products out there. I do want to hit on, I think Joe had a good point in terms of enterprise imaging and the fact that it's not always well defined. I'd say in this context, I'd lend my own definition, especially with regard to COVID-19, and that is enterprise imaging. I think in the general context, we should probably look at it as really consolidation of imaging data and ensuring that we actually have image availability across an enterprise or anything that is pertinent for diagnosis or even clinical reference. So the problem that we face is In terms of the organizations that had not been moving in that direction thus far, they're now reaching, they're now seeing the pains from that, in which those who had a good strategy, that image availability is there. They've either migrated and consolidated, or they've federated the data, and everything is there that they need to diagnose appropriately in terms of pertinent priors. When you start talking about other organizations that have not prepared for this, it's very hard right now because the mobility, the amount of staff they have, and moving things around, even if we're talking still about antiquated workflows of utilizing CDs and DVDs, that becomes very problematic right now. We're noticing less FTEs, and then still having these manual processes that are very FTE intensive. So in terms of cost savings and getting towards a true enterprise imaging strategy, which be, in my mind, inclusive of image exchange as well, I think those basic things really either set up an organization well or set them up for some major deficits right now.
I'm no clinician, but from what I understand of the situation, it is, would we describe this as an imaging intensive condition? I mean, we see the lung scans. So, but are those all coming out of radiology? So they're not being taken here, there, and everywhere in the health system. What are your thoughts on that, Chris, as far as you understand, actually what's going on the ground?
If you think about, let's pick imaging. I'll pick on ultrasound as a good example of where we're going to challenge this thing. If I've got patients scattered all over the hospital in areas where I'm segregating my COVID-19 patients from other areas in the hospital, and I'm doing imaging, I'm bringing imaging to them, portable ultrasound devices are very attractive relative to a cart, relative to dragging somebody to a CT scanner or something like that down in radiology. So then you have to ask yourself, great, these organizations, we're seeing buy requests for significant numbers of these portable ultrasound devices. How is that integrated into radiology? Are you doing an order for every one of those things? Are those devices DICOM enabled so they can do a DICOM store out? Are they DICOM modality work list enabled? Can I query a work list from an order that probably doesn't exist to get patient demographics and procedure information? Can I put it together and store it and save that so it becomes part of that medical record and accessible to any other physician future in the treatment of patients? We see how they're changing over time. So I think kind of the traditional radiology model is being stretched, and if I just focus on that point of care ultrasound space, it's bringing the same encounter-based point-of-care ultrasound problems that you see outside of radiology are now being faced by the enterprise as a whole. You want to think about it as radiology, and it may be covered under radiology, but are they really well positioned to deal with it?
Joe, any thoughts on that, Joe?
Yeah, I agree with everything that's been said, but I think that we also have to sort of keep in mind the fact that some of the greatest benefit from going to an enterprise solution may result outside of the classical imaging areas of radiology, cardiology, etc. So it may not be in the context of COVID as much of an issue, but certainly areas such as wound care management and pathology and some of these other areas are going to become much more intensive and probably benefit much more in terms of an enterprise solution compared to, say, radiology and cardiology.
Yeah, I think that's a
Brandon, any more thoughts there? Oh, go ahead, Chris.
Let me hop in here. It's just, you look at these other departments, and the problem is they don't have any infrastructure. So they're using imaging. They're using ultrasounds. They're using cameras. They're using video capture. They're using anything they need to do to image. But are they associating that with the patient data? Are they storing it? Are they managing it? How are they exchanging it? I mean, Brandon mentions image exchange. Are they texting images to each other, putting them on thumb drives and passing them around? How many violations of our PHI standards and our organizational information management standards? I mean, we've joked for years about this being the wild, wild west outside of radiology and cardiology. It's ugly out there. And I think situations like we're facing now with this pandemic are just kind of, it shines a light on things in a way that you can't just sweep it under the covers and pretend it's not going on.
I would agree with you. I would agree with you fully, Chris. I think, I mean, we work with, some of the most educated individuals being clinicians, in the sense that if they need to do something to treat their patients, they're going to get very creative. This has been going on for a while. And if an organization is not adapting with them and providing them with viable solutions, they will find a way to work around that and get what they need. And chances are they're not thinking about security protocols. In fact, I can guarantee you they're not. They're just trying to get what they need at the time that they need it. And yes, they'll take pictures with their iPhones, they'll exchange that around, and that's very problematic. We absolutely don't want to fall off the wagon, if you would, in terms of our security protocols because of these type of situations in which we're really scurrying to exchange information around. So it is very important to have that strategy, to understand how that's going to be accomplished. And even still, if organizations were not set up with this previously, this is, if not perfect, it's a forced time to have that conversation. I think there's no way around it. In terms of if we're worried about cost-benefit analysis, it's a slam dunk. It's not a hard thing to calculate.
Very good. All right. Next question. Many health system employees, including clinicians, are working remotely whenever possible. What are the unique challenges involved with allowing radiologists to read images from home? Let's go with Joe.
This has been a raging question for years, and I think that what it comes down to today is display quality and resolution as well as bandwidth. And certainly things are much better than they used to be, but the other aspect I think of that is also security. So if it's using systems that require transmission of patient data, that does open up the whole can of worms in the context of security aspects that are going to need to be addressed, or at least in the context of remote reading, making sure that that information is handled correctly. I think also there's the unwritten issue in the context of how do you maintain those remote read capabilities. So I'm always reminded of the instance where IT has been delegated to support those people, which may or may not mean that the equipment that's being used is being provided by the hospital or it's the radiologist's own equipment. But in either case, if IT is expected to support them, one has to be very sensitive to addressing those people's needs, either by doing it completely remotely, or how do you send personnel out to those radiologist homes to maintain those equipment. So I think there's a lot of issues that have to be addressed to do it correctly and expeditiously.
Not easy. Brandon?
I would agree with Joe. I think he hit a lot of really good points in terms of the challenges we face. I mean, it goes down to you usually have a multitude of scenarios in terms of what's going on with your remote workstations, remote readers. Did you set up a true strategy and standard from the get-go in which the organization provides all of their own image devices? That's expensive. That doesn't always happen. That's not always an option. So if that's not, it creates some issues, whereas a lot of information security officers do not want to provide VPN access direct from an unknown device coming into their network. That creates potential vulnerabilities. And what I would say to that is when these VPNs are set up, I thought I lost the camera there. When these VPNs are set up, really want to make sure that they're locked down. that they're not open to the entire network of the organization, because that could introduce some other vulnerabilities there from an information security perspective as well. I think it's probably the most important thing to be concerned with right now, because when we have times like this, unfortunately, there are individuals and groups out there that take advantage, and we want to make sure that we're staying protected with our secure information.
Chris, Joe, and Brandon both mentioning security as one of the big issues, and managing the whole situation. The organization sounds like it has to really decide how committed it's going to be to standing something like this up, and there's a significant amount of investment involved on a lot of people's parts. So your thoughts?
I'm going to get kind of concrete about some of this stuff, because I mean, if the organization did it in the past and they're set up for remote reading, that's one thing. But I think the majority of organizations are not set up for their entire radiologist workforce to read remotely. And when you start looking at the deals, okay, what kind of PCs do they have at home? Are they on IBM and Macintosh? What's their CPU speed? Is this an old machine from way back? A laptop? What kind of memory do they have on this thing? What's the requirements of the application, the PACS workstation software that's being installed? Do they have the appropriate monitors? What operating system are they running? Are they running a supported version of Windows, for example? What does their home networking look like? Are they hardwired? Are they wireless? Is it running well? What's the provider bandwidth and latency on this thing? We've mentioned the VPN. Do they have an appropriate place in the house to read from? I mean, how many people are we seeing working from home right now with their, families and kids and dogs running through because there's not a good spot in the house to do it? You get into what about the libraries that need to be installed, supporting libraries for the software, the radiology workstation application itself. Does the facility have the bandwidth to push full DICOM current studies and relevant priors over their existing network to all these radiologists who are now at home? And we've seen that come up again, where the facilities, some invested in networking infrastructure in advance, some are tapped. They have more people working at home. They're already pegging the ability to get that data out onto the WAN, into the cloud, onto the desktops of the people working remotely. And now you're going to add a radiology load on top of that. It may simply not be feasible for them. And that's where, other things start looking at other approaches for dealing with this. Cloud models, server-side rendering models, things that change the rules in some way from the traditional kind of heavy radiology workstation client. And then you also have to think about integrations. How are you driving your work list, right? Is your work list running remotely too, and you're launching that application on a local desktop? What about your dictation? Is your dictation system also installed locally? Are you using a cloud-based dictation system? How are you going to deal with that? So when you go and you deal with, okay, in a hurry, solve all these problems for a significant number of radiologists that are, need to work at home, on top of everything else you're dealing right now. My argument is, if you didn't do it in advance, doing it with your traditional thick client radiology workstation and dealing with all those challenges may be a non-starter. You got to change the rules in some way, and I'll have some suggestions on how to change the rules, but I'm just going to say this is a weighty problem.
Anthony, one other thing that never really gets addressed, but there's the whole liability question as well. So if IT is expected to support these people, how do you deal with the IT person that goes out to support the radiologist, and he doesn't happen to be home, but his 14-year-old daughter is at home? So there's a lot of those kinds of risks that case studies, examples that have been presented that I think also have to be addressed in terms of how are you going to support those people remotely? Yep.
It's a big bowl of worms that you open up. Well, and Chris, this is your point, doing it in a hurry. So I'm going to let Brandon start off, but, Chris laid it out there. How long does it take to do it in a hurry? Is it even feasible? Is there low-hanging fruit here? that you can do to put people, because there's a correlation here between what you can do remotely and your volumes in terms of your dollars, right? So if I can't do any of this stuff, I'm not getting paid for any of this stuff. But if I can figure out a way to do it remotely, I know I can keep my cash flow going as a health system, and I can treat patients better, because you talk about all these things that are being canceled and put off. There's going to be a clinical price to pay here. There's going to be people that needed that now, and yeah, we put it off because it was quote unquote elective, but there's different degrees of elective, right? My mother needs her hip done. She was supposed to use incredible pain. So that's probably going to be put off. How elective is that when you're suffering a lot? So just your general thoughts there on getting something going in a hurry for all the reasons, the clinical reasons and the financial reasons.
Yeah, Anthony, to your points, the question, I mean, if we're answering it simply, can it be done in a hurry? Yes. Can it be done in a hurry and be done well? Probably not. So if you weren't already prepared for these scenarios, to Chris's points, to Joe's points, if you're not already prepared, if you don't already have an enterprise imaging strategy that you've deployed with remote capabilities, you're still stuck at square one, and you still need to go through that process in order to establish these things. Just because we have an emergency situation doesn't mean that you're magically going to be able to stand up an enterprise imaging system faster. You still have to go through the due diligence and the process of doing it appropriately. Now, I would say to those organizations that aren't set up properly, if you need to do something in a hurry because it's an emergent type item, yes, there are some options that you can deploy in the interim to allow you to be able to function remotely. Will it be pretty? Will the workflows be good? No, but it'll be at least something that you can survive off of. But that also means that you need to start the process of thinking forward to the future and start developing that enterprise imaging strategy now, not waiting. I think that's really the key point here.
It's almost like, Chris, almost like a wake-up call. Would you describe this as perhaps a wake-up call for organizations that say, all right, we dragged our feet with this. We could have really used it now. It would have really helped us. But we're going to make sure this doesn't happen the next time around. So we're going to start this process. I don't know what can be done quickly to get them going now for this crisis. As Brandon was saying, maybe there's something you can do, but it won't be pretty. But you can start strategizing longer term and say, next time around, we're not going to be in this position. Your thoughts?
I mean, both need to be considered. There's what can be done in the present, and if you change the game a little bit, there are things that can be done in the present. They're not pretty, as Brandon says, but they can be effective. And I think it's absolutely time for the wake-up call. I mean, enterprise imaging is one of those things that some organizations get it, and they have a defined enterprise imaging strategy. They're executing on it. They've defined their governance. They have a budgeting model. They have identified specialties that are going to be kind of the leaders in this space. And others are absolutely, I mean, just kicking that can down the road, milking out their existing imaging solutions, continuing to invest in point specialty solutions, and just thinking the whole thing is going to go away, which it's not. And I think, like with the DIAM model coming up, there is models defining for what you should be doing in this in a multi-stage model. I won't get into that here, but let me jump ahead. But in terms of what can be done, I think the notions of what can be done boil down to changing the rules in some way. So one of the current rules of medical imaging, diagnostic medical imaging, is the vast majority of solutions are using a model where I have to push a full DICOM study and relevant priors to a workstation where I'm going to render those images on that radiologist workstation and display them. And that whole architecture makes this problem of a remote read really hard to solve. And if you want to solve that in a hurry, my suggestion would be don't use that architecture. There are alternate architectures. And the one I'll propose here, and I'll disclaim, we have a solution that does this, so don't think I'm not a biased point of view on this, but I think this is a fair, realistic assessment. If I can do the work, the server-side rendering work in my data center, I can push those images to, say, a virtual machine in my data center where I do the rendering work that would have occurred on the radiologist desktop, and then I HTTPS stream that data to a browser, any browser on any device, sitting on whatever that radiologist is running, Mac, PC, whatever, and I have some appropriate monitors, glass to look at that on. I've just made the problem vastly easier to solve. If I take it one step further, and this is a plus minus situation, if I do the rendering in the cloud, right, now I don't really have that dependency to set up VMs and whatnot inside the data center of the organization, but I've created the problem that I still need to push those DICOM studies from on-premise into the cloud where they can be rendered and served to the radiologists. So I think the way of making this easier from a radiologist perspective is, while it can be done, the notion of using the traditional client-side rendering model and pushing full studies out there, if you haven't prepared for this thing and that's the model you're trying to use, I think you're in trouble.
Joe, that's a lot to react to there.
Sorry.
Yeah, I would express it in this way. I would say that I think there's a major differentiation in the context of talking about utilizing existing diagnostic systems such as a radiology PACS to address just the radiologist, as opposed to if you're on a path for a real enterprise scale solution, then you probably have had to look at the question of how do I interoperate imaging with the EMR. And I think that that's a key aspect in the sense that if you have image-enabled your EHR, then you do have a mechanism to present some level of imaging to a broad range of clinicians, and that's more of a true enterprise issue than, say, allowing a radiologist or a cardiologist to view images in their home. So I think that from a rapid deployment perspective or whatever, if the hospital has addressed integration with the EHR, then it does present an opportunity for at least some capability of presenting image to clinicians external to the facility, and that may be a more valuable long-term aspect than just being able to provide the clinician, the diagnostician, with their PACS system in their home. So there is that differentiation, and it's going to be a question of where do people find the best bang for the buck.
Brandon, you want to react to anything Chris or Joe said?
I think they both have really good points. I mean, what it comes down to is what was stated earlier, is if you don't have the strategy already there are a multitude of solutions out there. Chris touched on it in terms of a streaming viewer. I mean, it's night and day if we're talking about antiquated traditional PACS architecture. Yeah, you're going to have some major limitations in terms of the size of the data sets you're trying to move across the network. It's going to be problematic. So there's a multitude of different strategies that can be deployed. The question is, do you already have them in place, and what is it that you want to do long term? If we're just patching, it's kind of an interesting patch strategy to go with in the interim. I think you want to make sure you're thinking it through in terms of the long term benefits as well.
All right, very good. Joe, let me get this one over to you. What are the roles AI and clinical decision support might play in terms of diagnosing and treating COVID-19?
Well, I think there's some emerging capability there. There's been a lot of press that I've seen lately that would suggest that being able to use AI to analyze chest films probably has some merit in terms of detecting COVID. So I think that certainly AI is going to play a role in terms of diagnosis. And then in terms of clinical decision support, probably not as big of an impact at this juncture, given that perhaps portable ultrasound and regular chest X-ray may be more valuable at this point. There's been a lot of controversy in the context of suggesting whether CT is appropriate for COVID diagnosis. So the clinical decision support is probably going to apply more towards the high-end imaging devices like CT and MRI than some of these other areas. But there may be some benefit to be derived in the context of some of the rule sets developing or emerging in support of COVID diagnosis. Also, I'd suggest that the whole notion of AI and clinical decision support may have more value outside of the classical imaging areas than inside. So one facility that I've conversed with has made the point that presenting an AI-analyzed image to a radiologist 10 minutes before he reads the film is not going to be as cost-effective or as valuable as using AI to assess wound care and imaging and prescribing antibiotics to address it quickly. So I think there are opportunities for AI and clinical decision support, but they need to be done within the context of a true enterprise scale solution.
Very good. Chris, any thoughts on that?
Yeah, I think this is kind of an interesting space because there's a lot of AI vendors that are all trying to apply their technologies to this space and come up with some useful stuff. I'll pick one particular example that we're working with. We have a partner that we license some of our image analysis segmentation capabilities to, that develops a lung product that basically uses artificial intelligence and machine learning to analyze chest CTs and come up with all kinds of interesting views, topographical NPRs, quantitative analysis, looking at different segments of the lungs and the level of compromise and whatnot. And you can use some basic DICOM integrations to send, say, a CT series. They do their magic and they create some results. They create some images, they create some reports, kind of the same model that you see with a lot of these AI algorithms. And they're trying to figure out how to leverage their existing capabilities and apply it in the COVID-19 era. And I have no idea how fast or how effective that's going to be. That's really outside my core area of expertise. But kind of from a longer term, this is not an immediate term thing, but one of the things that has got us thinking is what would it mean to do tighter integrations of this class of product into the viewing technology? So really giving a more intimate, rich set of tools to radiologists and pulmonologists who can leverage these type of algorithms, the imaging results, the navigational capabilities, looking at these things, looking through lung fly-throughs, looking at the airways next to the vasculature, looking at the quantitative analysis, measuring various aspects of this thing. If we can leverage these tools and give radiologists, pulmonologists better, richer tools, then maybe they'll be, in general, these tools tend to make people faster at reading. They tend to give better quality results. I'm going to grossly generalize on a bunch of different results. But if you look at how this AI maps the things, at speed to read, quality of read, and the ability to detect things that are less common or rare are three recurring themes that I see as key benefits of AI and machine learning algorithms well applied to this space. Whether that's going to pan out for COVID-19, whether CT is appropriate, whether the vendor I'm talking about and any number of other vendors are going to be effective in the timeframes required, I'm not sure. I'm hopeful, but I'm not sure.
Brandon?
I think Joe and Chris hit on some really good points. In terms of AI, there's a multitude of algorithms obviously being developed right now to try to attack this. The question is timing. I mean, I really hope that it is a good exercise, but a wasted effort in the fact that we're able to pull ourselves out of this before those things even come to fruition to be able to assist us. I think clinical decision support, as Joe alluded to, is definitely going to probably play more of a key factor in terms of making sure we're appropriately triaging patients based off of infection. In terms of the screening techniques, I mean, we have chest X-ray as our basic, and then we also have point-of-care ultrasound. The beauty that comes with, say, point-of-care ultrasound is there's less stuff to clean. When we put a patient into a CT room, if we don't have a designated CT scanner or a facility doesn't have multiple CT scanners, you're having to clean that room each time to make sure that you're not potentially exposing other patients. That is an incredibly inefficient workflow. And any place that has a CT scanner, and the multitudes, I mean, they're usually running that scanner 24/7, depending on the size of the facility. So having an interruption like that becomes very problematic in terms of being able to serve enough patients appropriately. So if you can use other screening mechanisms to try to triage, I think that, especially with less cleanup, that provides some value there. But I'd be interested to see what happens. I hope obviously people continue to, and companies continue to develop things that will help us in the future to detect other things as they come up if we have any other pandemic situations. I think this is all a learning lesson right now. But in terms of the role right now, I think it's very hard to say.
All right, very good. I want to quickly get out our audience poll, which is going to be launched right now. I can get our panelists to vote as well. Organizations that have moved towards an enterprise imaging approach have been in a better position to deal with the COVID-19 pandemic. So record your votes. I think I know what our panelists are going to say, but let's all vote, and then we'll take a look at that. We don't have too much time left, but I do want to get to our Ask a Co-Panelist feature. I want to start with Chris. Please go ahead and ask your co-panelists a question.
Sure. Brandon or Joe, either one. In terms
of
the...
You can put it to both of them. Yep.
Both of you. In terms of organizations, in terms of their preparedness or lack of preparedness for this COVID-19, can you give me the kind of concrete characteristics of things that maybe they did that put them in a better position, or things that they failed to do that is making their life a lot more difficult right now?
Joe, you want me to
fire on
go
that
ahead,
first?
Joe.
I think that one of the key aspects in terms of their response, as well as the whole question of enterprise imaging, is in the context of governance. So facilities have to put together a governing organization or committee, if you will, that addresses all of the imaging needs and make sure that there's proper representation on that so that there aren't areas that are being overlooked. And I think that if a facility has had some level of governance and an ability to address IT issues in that context, that they're going to be better positioned to deal with emergencies such as COVID. Brendan, you can chime in.
I think you hit the number one item on the head. Obviously, if you don't have the appropriate representation from the get-go, you're not going to get very far. The other is decision making in terms of what that steering committee or governance committee decides upon. You think about what type of technology they're utilizing. So if they're going with the traditional PACS model, which still happens to this day, it might be appropriate for some organizations up until this point of realizing the need for some more robust remote capabilities. That may change their approach going forward. So I think in terms of being prepared, it comes down to number one after governance is probably network infrastructure, depending on the solutions that are being deployed.
All right, very good. Chris, we've got our poll results in. You want to take a guess before I share them at the breakdown? Percentage. Give me a percentage, Chris. Come on.
Percentage? give the people who would be attending this type of thing, I'm going to guess we're probably about an 80 or 90% minimum.
Agree? 80 per 90% agree? Well, let's share the results. 94%. Yay, Chris. Well done. You get a prize. It's in the mail. Just kidding. Very good. Chris, I'm going to give you an opportunity for any final thoughts, and then we're going to wrap it. So anything you want to leave the audience with, just your thoughts. They're going to be on the gamut from people who listen to this, farther along to nowhere at all, to everywhere in the middle. So any kind of general advice to give them on this topic?
The general advice is if you don't have an enterprise imaging strategy and governance in place right now, you need to really rethink this. I think tactically, and I'm going to say this is obviously for the benefit of my company, but more importantly for the benefit overall, we're actually working on a solution that we can make available to our customers and to not necessarily Hyland customers, any customer, a mechanism that can help solve the problem of reading at home or capturing ultrasounds and making sure that you're getting good quality metadata and storing that in whatever your repository of choice is. We're trying to figure out ways within the enterprise imaging space in Hyland of giving you tools that can be quickly implemented to address this problem. So if that's a problem that you're facing and you're interested in hearing what we have to say, please reach out to us and we'll see what we can do for you. And we're just trying to, at the end of the day, I don't want this to sound commercial. We want to do the right thing first, right? We're all affected by this. I'm personally affected by it. I've got challenges in my family where all of this stuff is having a material impact on my life. I would really like us all to think hard about what we can do to make this a better situation.
Very good, Chris. Well said. Well said. All right, that's about all we had time for today. Regarding continuing education, you can use our final slide in this deck for your CEU needs. You'll receive an email when the on-demand recording has been posted to our YouTube channel and to Hyland's partner channel that they have with us. If you'd like to sponsor one of our upcoming events or book a custom event, you could reach out to Nancy Wilcox from our team. And you could go to our site to register for our scheduled upcoming webinars. With that, I want to thank our panel, brilliant folks, some of the best imaging minds you're going to find, Joe Marion, Brandon Taggart, and Chris Magyar. And I want to thank Hyland Healthcare very much for making this conversation possible. And I want to thank you for attending. So with that, everybody have a wonderful day. Thank you.
Thanks for attending.
Thank you.
Thank you, Anthony.